Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for May 21st, 2025. Thank you for joining us today, and thank you to the current Osteoarthritis Action Alliance sponsors shown here who help support our work, which includes the monthly Lunch and Learn series. Now it is my pleasure to introduce today's speaker, Ida K. Haugen. Dr. Haugen is a rheumatologist and senior researcher at Diakonhjemmet Hospital in Oslo, Norway. Her field of interest and expertise is hand osteoarthritis, and her research focuses on mechanisms of pain and disease progression and the management of hand osteoarthritis. She is a project leader of observational studies and 2 randomized controlled trials, examining the role of inflammation and the efficacy and safety of different anti-inflammatory treatments, such as methotrexate and intraarticular corticosteroid injections. The title of today's presentation is Update on the Management of Hand Osteoarthritis. Welcome, Dr. Haugen.
Thank you very much, Katie. Thank you so much for the invitation to be here today, and I've very much been looking forward to it. So I will give you an update on the management of hand OA, and these are my disclosures. So in this presentation, I will mainly focus on pharmacological management since we have limited time. I will present the current treatment recommendations from the European Rheumatology Organization, EULAR, and I will also present some results from new successful trials. So the management of hand OA can be summarized in this treatment pyramid. And for all patients with hand osteoarthritis, we recommend education about the disease, hand exercises, and assistive devices. For some patients, this will be enough and give symptom relief. For other patients, they need additional treatment. And that can be thumb burtosis if they have OA in their thumb-based joints, and they may need topical or oral NSAIDs, and some also need intraarticular steroid injections. For a few patients, surgery is also needed. So as mentioned in this presentation, I will mainly focus on the pharmacological management. But before I do so, I would like to show you this link regarding hand exercises. And if you click on the QR code, you can get access to the website for our hospital. So here you can see videos on how to do hand exercises, both to increase the grip strength and also increase the mobility. And one warning is that everything is in Norwegian, but it still may be useful for some of you because you can see the video, and if needed, you can also translate the text. So these are the EULAR recommendations regarding pharmacological management for hand OA. So as you can see, if non-pharmacological management is not enough for symptom relief, topical treatments are preferred, and then we are mainly speaking about topical NSAIDs. In some patients, oral NSAIDs may be needed. However, the expert advice is that these should be used in lowest effective dose and preferably on demand. And as you can see, paracetamol or acetaminophen is not recommended in these guidelines. And we do not have any trials on hand OA for acetaminophen. However, we know from trials on knee OA that they are less effective than NSAIDs. You can see that there's a weaker recommendation regarding chondroitin sulfate, that it may be considered, and this is a weak recommendation because we only have one trial. And I will not discuss that any further in this presentation. You can also see that there's a recommendation regarding intraarticular steroids, and the experts said that they should not be routinely used. However, they could be considered in painful and inflammatory interphalangeal joints. And I will come back to this later in the presentation. And regarding DMARDs, they should not be used according to the EULAR guidelines. Okay, so I will first discuss the use of NSAIDs, and I have focused on the topical NSAIDs for this presentation. And there are two previous studies that have shown that topical NSAIDs, they have similar efficacy as oral NSAIDs, but of course they are preferred because they do not have the same systemic side effects as the oral NSAIDs. There's only one study on topical NSAIDs compared to placebo. And this is a quite large study performed many years ago in 2000, published in 2009. And they included almost 400 patients. They had 6 co-primary endpoints. And for 5 out of these 6 endpoints, they found that the topical NSAIDs was better than topical placebo. However, you can see from this graph that although there's a larger pain reduction in the NSAIDs group, there's also a pain reduction in the placebo group. And the difference between the two groups was around 7 points on a 0 to 100 scale. So you can see that both groups, they still have some pain despite using topical NSAIDs or placebo. So because of this study, topical NSAIDs are recommended by EULAR. However, if we look at other trials, they have shown that topical NSAIDs have similar efficacy as herbal gels, and they are inferior to steam baths, finger showers, and leech therapy. So that means that we should have more studies looking into the efficacy of topical NSAIDs in hand away. I will then move on to intra-articular steroid injections. And as I mentioned, they should not be routinely used. However, they can be considered in painful and inflammatory finger joints. And this recommendation is based on one single study, quite small, of 60 patients. These patients, they have symptomatic OA in at least one finger joint. They did not necessarily have had inflammation, which is a bit strange when they treat the patients with corticosteroids. However, the patients could be randomized to 2 groups, either a corticosteroid injection in addition to local anesthesia or local anesthesia alone. So in this trial, they found that the steroid injections led to less pain at movement and also less joint swelling after 8 weeks and after 12 weeks. However, they did not find any difference for pain during rest or function of the hand. And as expected, they also saw smaller differences between the corticosteroid injection group and the control group after 48 weeks, which is also in line with what we see in clinical practice, that we see that corticosteroid injections, they have a more short-term effect. So what about corticosteroid injections in the thumb-based joints? Here we have even less evidence. A systematic lit review was published almost 10 years ago. In this study, they included 3 placebo-controlled trials, including around 200 patients in total. None of these 3 trials could show that corticosteroid injections were better than saline. And also, when they combined all the trials, the pooled mean between group difference was not statistically different. And that's why EULAR is not recommending corticosteroid injections in the thumb-based joint. However, there are quite a lot of limitations to these trials. One point is that the primary endpoint in all 3 studies was after around 6 months. And as I expected, we usually expect a more short-term effect. So, and maybe if they had a short-term effect, the pain may have got worse after 6 months, even if they had an effect in the beginning. Also, in these studies, they did not necessarily require inflammation as an inclusion criterion. And also none of the studies used ultrasound guidance. So in my opinion, we really lack studies of good quality on the efficacy of corticosteroid injections in the thumb-based joint. And because of that, we are currently doing a study on patients with OA and synovitis in the CMC1 joint in Norway. And we will recruit more than 350 patients at 6 centers in Norway. In this study, the patients are randomized to one of 3 interventions. One group will get a multimodal occupational therapy intervention, which includes hand exercises and hand orthosis. For the 2 other interventions include corticosteroid injections or a saline injection. And the study is double-blind, which means that the assessor and the patient is not aware whether the patient is getting a corticosteroid injection or a saline injection. And we follow the patients for 6 months in the trial, and the primary endpoint when we compare the 2 injections is after 4 weeks. So currently we have recruited more than 50% of the patients, and we hope to finish the recruitment in about a year, which means that we will have the results late in 2026. So I will continue with corticosteroids, but move on to oral prednisolone. In the EULAR guidelines in 2019, prednisolone was not recommended. And that was due to conflicting evidence regarding the efficacy of low-dose prednisolone of 3 to 5 milligrams per day. However, after the EULAR guidelines were published, a group in Leiden in the Netherlands published the results from the HOPE study. In this study, 92 patients with hand OA and inflammation were randomized to 10 milligram prednisolone per day or placebo, which means that they used a considerably larger prednisolone dose than the previous study. The patients were treated for 6 weeks before they tapered the treatment and then discontinued. And you can see here on this graph that the patients treated with prednisolone had a much larger pain reduction than the placebo group. And you can see here, after 6 weeks, the between group difference was 17 points, which is statistically significant and also considered clinically relevant. And if you remember back to the study I showed you on topical NSAIDs, they found a difference of about 7 points. So this is considerably larger. However, you can see here that when the patients stepped down and then discontinued the treatment, the pain also increased for patients who were treated on prednisolone. So that means that it has an effect, but the pain will come back when you stop the treatment. And we are also well aware of all the side effects of prednisolone. So the authors do not recommend to use prednisolone for a longer term. However, prednisolone may be a treatment option if short-term pain relief is needed for the patient. Okay, so I will then move on to the use of DMARDs. That stands for disease-modifying anti-rheumatic drugs, and they are used for systemic inflammatory joint diseases, such as RA. In the EULAR recommendations, these drugs were not recommended, and I will challenge this view a little bit in this presentation. So the first drug I will discuss is hydroxychloroquine, and this is a drug that is less frequently used now for rheumatoid arthritis, but still used a lot for diseases such as systemic SLE. And the take-home message from all these 4 randomized controlled trials in hand OA is that it is not effective in hand OA, even in patients with erosive disease and more severe inflammation. So all these 4 trials, they failed to meet the primary endpoint of pain, and they also did not show any effect on disease progression. So in my view, hydroxychloroquine does not have a role in the management of hand away. There's more promising effects of methotrexate, and this is also a drug very commonly used, for example, in the treatment of rheumatoid arthritis and psoriatic arthritis. In the EULAR guidelines, there was no recommendation regarding methotrexate because at that time we didn't have any results from randomized controlled trials. However, the recent years, 2 randomized controlled trials have been performed, one study in France and one study in Australia. And you can see that the dose is a bit different in these studies. In the French study, they used a dose of 10 milligram per week, while in the Australian study, they use a dose of 20 milligram per week, which is comparable to the dose that we use for treatment of rheumatoid arthritis. You can see that there was an effect on pain in both studies, however, only statistically significant for the larger study using also a higher dose. However, also in the French study, there was a possible effect on disease progression, which is really interesting. So both these trials have shown some promising results. I will go more into detail on the Australian study. The methods trial. In this study, 97 patients with hand away and inflammation on MRI were randomized to methotrexate or placebo, and they used a dose of 20 milligram per week, as mentioned before. The primary outcome was pain after 6 months, but they also looked at other secondary outcomes such as function in the hands, grip strength, health-related quality of life, and safety. And you can see here that the pain reduction in the methotrexate group was larger than the pain reduction in the placebo group. But you can still see that the patients are still experiencing quite a lot of pain, but the difference between the two groups is statistically significant and also what we consider clinically relevant. So you can see that the difference in pain between the two groups was 10 points on the 0 to 10 scale. They also found a better effect of methotrexate than placebo on another hand pain scale called the Haugen. They also found that methotrexate reduced the hand stiffness. There was a trend towards better function in the methotrexate group. However, this difference was not statistically significant. And it's also interesting to see that other studies on knee OA have also shown very promising results on methotrexate. And these are results from a recent meta-analysis published only a few weeks ago, where they summarized all the trials on methotrexate. You can see that out of these 5 trials, 4 of them showed a positive effect of methotrexate. There was one trial, the one from 2007, showing no difference between the groups. However, in this trial, they used a very low dose of methotrexate, 7.5 milligram per week. And we are also performing a study on methotrexate at our hospital. We are including 163 patients with erosive hand away and inflammation on ultrasound. And we have chosen to treat patients with erosive hand away because we know that these patients, they have more severe inflammation, they have usually more pain, and they also have more disease progression over time. We are using the same dose as in the Australian study methods, which means that we are treating the patients with 20 milligram per week or placebo. And it's of course double blind. We are following the patients for 1 year, and we also have imaging outcome measures such as MRI and X-rays. And we have so far included almost 90% of the patients, and here also we expect the results to be ready in 2026. And it will be very interesting to see if we can also show the same positive effects of methotrexate as has been shown in previous trials. I will then move on to biological DMARDs in handaway, and several biological DMARDs have been tested, including anti-TNF, anti-IL-6, and anti-IL-1. And the conclusion is that all studies have failed to meet the primary endpoint. In general, no or only weak effects on pain and other patient-reported outcomes. There was some signal that TNF inhibitors could alter disease progression. However, in general, these drugs are not recommended for the treatment of handaway. I will also shortly mention one study on denosumab in erosive handaway, and this is a drug that you may have heard of from the treatment of osteoporosis. This is an antibody towards rank ligand, which means that it inhibits the binding to rank and thereby inhibits the bone loss. And we know that in erosive handaway, there's central erosions with bone loss and bone damage, and there's therefore a rationale to test if this treatment can also inhibit the radiographic progression in erosive handaway. So in this study, they randomized 100 patients with erosive handaway to denosumab or placebo. And they were treated every third month, which means that they were treated more often than patients with osteoporosis, where the drug is used every 6 months. In this study, they were followed for 48 weeks. After the RCT was finished, all patients could be treated with denosumab, so they had an open label extension phase. And all patients who were treated on denosumab continued with the treatment or switched to another osteoporosis drug after the study, because we know from osteoporosis that when you quit denosumab, you can have increased bone loss. So the primary endpoint in this study was not pain or other patient-reported outcomes, but a change in radiographic progression. And they used something called the GUS score, which I will not go more into detail. But a positive score, here shown in red, means more repair, and a negative score means more joint damage. So they found that in the denosumab group, they had more joint repair. And you can see here that when after the RCT had finished and all patients could be treated with denosumab, also those who had placebo initially, shown in blue, you can see that those who switched from placebo to active treatment also had more joint repair. However, they found no difference in pain and function after 48 weeks. However, they found that patients who had been treated with denosumab during the whole period had less pain and better function after 96 weeks. So I will not recommend patients with handaway to be treated with denosumab due to the possible rebound effect, for example, and of course it will be out of the indication for the drug. However, maybe it could be a drug of choice for persons with both osteoporosis and erosive handaway. So the conclusion in this presentation is that topical NSAIDs are preferred over oral NSAIDs when pharmacological management is needed for handaway. There's evidence that corticosteroid injections can have an effect in the finger joints. No previous studies have shown an effect of these injections in the thumb-based joints. However, we lack well-designed studies. One study has shown that oral prednisolone is effective if you use it in adequate dose of 10 milligrams per week. However, one should pay attention to the side effects and should not be used for a long term. There's evidence that methotrexate can be effective if the patient has handaway and inflammation, and there's better effect if the dose is higher, for example, 20 milligrams per week. Neither hydroxychloroquine, anti-TNF, anti-IL-1, and anti-IL-6 have a role in the management of hand away. Regarding other treatments, a study has shown that denosumab can inhibit progression in erosive disease. With that, I want to thank you for the attention and happy to answer any questions.
Thank you so much for that presentation, Dr. Haugen. We're especially grateful to you for your sharing your expertise in hand OA, because we do know that's a topic of great interest to our audience, given that a lot of attention around OA is given toward knee and hip. So thank you
Yeah.
for filling this gap. We do
Thank you
have
so much.
we do have time for a couple of questions, and I see that a couple have already come in, so we will get to as many as we can with our remaining time. First question, Dr. Haugen, what concentration of diclofenac is needed to be effective? Off-the-shelf topical products are only 2.3%.
Yeah, that's the same dose as we are using in Norway. So we are not using any higher dose in Norway either. And I think the trial that I referred to earlier also used that dose.
Okay, thank you. And another medication question that was submitted ahead of time is from a clinician who asked, "I'd be interested in your opinion or your experience related to a low dose of naltrexone for hand arthritis pain."
Yeah, so I personally do not have any experience with that myself, and I'm also not aware of any clinical studies looking into the efficacy of this drug in hand away.
Okay, thank you. We had a couple of questions related to guidelines. So you were referring to the EULAR guidelines throughout, and here in the US, we often use other guidelines, although the EULAR guidelines are certainly relevant, and many clinicians do reference those. Would you say that the EULAR guidelines can be applied to American patients?
Yes, I would definitely say so. And of course, the EULAR guidelines are based on studies that are not necessarily have been performed in Europe. And also the ACR guidelines were published around the same time. And I didn't have the time to show the recommendations from both guidelines, but the ACR guidelines are very similar to the EULAR guidelines.
Yes, when I saw that question come in, I quickly pulled up the ACR guidelines, and they are very similar in terms of your pyramid, with starting with the self-management strategies and the bracing and the exercises,
Yeah.
and then moving on up.
Yeah, there's no big difference between these two guidelines regarding the management of hand away.
Great. Question, I know your talk focused on medications, and I'm just curious if you, again, I know you mentioned a few strategies such as hand exercises and orthoses and occupational therapy, but kind of thinking for someone maybe who is employed in a job that has repetitive motions or where they use their hands all day, do you have any tips for them kind of as they move through their day, what they can do to manage their joint pain?
Yeah, of course, it's always important to sort of move the joint, but I also understand that if you have repetitive movement, that can also cause pain for some patients. Um, often it's useful for these patients to visit, for example, an occupational therapist, where they can get some advice regarding what kind of exercises to do. Maybe they need some devices that can help them during the day. Maybe if they have thumb-based OA, they can use an orthosis. And also topical NSAIDs is also usually a safe treatment to use if we experience pain during the day.
Okay, thank you. So again, a combination of things is probably going to be a good approach.
Yes.
Okay. I see one more question in the chat that we'll go ahead with. Do you have any thoughts, Dr. Haugen, around why therapies targeting IL-6 and IL-1 were ineffective? How well established are the inflammatory pathways around hand OA?
Yeah, so we know that in hand OA, we know that inflammation is common, and we also know that it's associated with pain and also disease progression. So it's a big disappointment that all these trials have failed. But it could be that these pathways are not necessarily as important in hand away as we know they are in RA. We know that, for example, there are different cells in the synovitis in OA compared to RA. And also in some trials, the treatment has not been for a very long time. They have also not been followed for a very long time. So there could be a lot of different explanation for why these drugs have failed in previous studies.
Dr. Haugen, we're going to squeeze in one last question here that just came
Yes.
in. Do you have any thoughts about the use of intra-articular NSAIDs such as Toradol? There are a few small studies about using this in knee-OA with good effectiveness and fewer side effects versus other intra-articular steroids.
So this is a drug that is not approved for use in Norway, as far as I know, or in other European countries. So I don't have any experience with it myself, and I haven't seen any studies on it either from hand away.
Okay, but maybe another one to keep an eye on.
Yes, for sure.
Great. Well, thank you again, Dr. Haugen, for your presentation today, and thank you to everyone who attended. In just a moment, we will launch a brief satisfaction poll, so if you have time, please answer those questions before you go. And as a reminder, there are still 10 more days of Arthritis Awareness Month. In the follow-up email to today's presentation, we will include some resources you can use to raise awareness on your social media channels. And finally, we hope you'll join us next month on June 18th, and that will be at a special time, 1:30 Eastern Time, for our Lunch and Learn presentation titled Personalizing Incretin Therapies for Older Adults, featuring Dr. John Batsis. So that concludes our presentation. I will put a link to that June webinar in the chat, so you can register for that. We'll include it in the follow-up email as well. Thank you so much, and I hope everyone has a great rest of your day.
Goodbye.